Good morning, everyone. It's the top of the hour, so I would like to begin. I'd like to begin with welcoming everyone to today's presentation entitled Improving Patient Outcomes with Lean and Six Sigma. My name is Jean Dufresne, and I will be your host for this event. Before we begin with the presentation, I would like to review with all members some housekeeping instructions. First, all participants have been placed in listen-only mode. We'll eliminate any background noise which can be disruptive to both the speaker and the audience. Next, please note the chat box in the lower left-hand corner of your screen. This chat box will be monitored for technical issues only. So if you have any issues logging on to the presentation, please type them there and refrain from posting questions in the chat box. At the conclusion of the presentation, we will unmute all lines for a question and answer session. Last and most important, a survey will display at the close of the web event. In order to earn a CEU, you must complete this survey, so please try to stay until the end to complete that. If for any reason you must leave before the end, keep the conference session open on your computer. The survey will remain live on screen until you can return to complete it. CEU certificates will be emailed only to those who submit that survey. And now it is my pleasure to introduce Casey Jones of Berkshire Medical Center. Casey Jones is a performance improvement specialist who has been with the Berkshire Health System for 10 years. Her focus is performance improvement, regulatory compliance, and population health. She's a certified Lean Six Sigma Black Belt who is able to use the Lean and Six Sigma methodologies to streamline processes, gain better staff engagement, and decrease the amount of time needed for projects by using rapid cycle changes to test change. She has a master's degree in public health and is a certified professional in healthcare quality. Casey, the floor is yours.
Thanks, Jean. So welcome, everybody. Today we're going to talk about using Lean and Six Sigma to improve patient outcomes. The goal, technical difficulties. There we go. The objectives of today's presentation are why choose Lean and Six Sigma, obtaining buy-in from our staff and providers, as we know this is critical for the success of our projects, how we select projects, how we can integrate this into our organization, using the Six Sigma toolbox, the impact on patient outcomes, hardwiring financial savings, and ultimately the engagement of our staff. Before I started, I wanted to give everybody a little bit of who I am, where I'm coming from a Berkshire Health System's perspective. So we are in Massachusetts. We're in the far western region bordering the New York State, Connecticut, and Vermont on all edges. We are an acute care hospital at Berkshire, a critical access hospital at Fairview, provider practices for Berkshire faculty services. We have a visiting nurse association with a hospice, and then we have our Berkshire Healthcare Division, which has rehab and skilled nursing. So that's just a little bit about who we are from a systems perspective. From a hospital perspective, where the majority of the work we're going to talk about today is coming from, is Berkshire Medical Center. So we're a 297-bed acute care hospital. We are a teaching hospital. We have medicine, osteopathic, psychiatry, and dental residents. We have a full-service emergency room, acute care, outpatient, and specialized services for everybody in Berkshire County, as well as the numerous visitors we get throughout the year. So how did we get started with Lean and Six Sigma? Our COO brought some success stories back from a conference. It made perfect sense with where senior leadership and our medical staff was, being very data-driven, evidence-based decision-making. The key was really selecting the right partner to work with our organization, because they had to encompass our goals, our principles, and not just say, well, this is how you're going to do it. So we were able to customize the program for Berkshire. We were able to align the program through project selection and really make it match our organization's vision, mission, values, and most importantly, our strategic plan. So our timeline. We started our journey back in November of 2010, and that was our first group of staff were trained. We called them waves of we would took 8 to 10 employees throughout different areas of the organization and did projects. We will talk in a lot more detail about how we selected those projects and why that was so important. So we did this wave of projects. So we had 8 projects running simultaneously, which we were very careful, and we'll talk about this some more in project selection, to make sure that we didn't overburden any one area of the organization, as these projects can be very labor intensive. So we did 2 rounds of this really intense project. Then we did a lean project where we did some waste walks, removed a lot of overhead. Then we did a third wave of Six Sigma training for belts. We trained green belts and black belts in that wave. Then we did some more lean, doing lean pods where we actually divided our senior leadership and basically created a competition, and we assigned them to other people's divisions and really looked for streamlining and were there ways to improve systems and structures, decrease or improve savings. And then finally in 2013, we did another round of green and black belts, and this is when we started instituting our yellow belt training. So currently, every supervisor, manager, middle manager in the organization who wasn't already a green or a black belt takes a basic performance improvement theory methodology, has to perform a project, has to show efficiency in at least 2 different tools, and then they gain their yellow belt and are then able to help work with other staff in the organization to help use our projects and do the project methodologies. So what's the difference? A lot of people say, oh, lean's the best way. Other people say Six Sigma. We've done a hybrid model of using both. So from a Six Sigma perspective, that's really the inch wide and a mile deep. You want to find out everything you possibly can about one specific topic. So we really delve into, our process mapping becomes very important because we want to know every possible step so that we can reduce waste in that one project. Then there's lean. With lean, you're kind of skimming the stuff off the top or the middle, depending on how long you've been doing this. And it's a real quick look at everything across a department, everything across an organization. So that's more of the approach of an inch deep and a mile wide. You find out as much as you can, a little bit about as many different things as you can. So you can see where both methods have their advantages. When we look at this more in a Venn diagram perspective, their steps are very similar. They're very customer focused. We're going to use the term CTQ or critical to quality. The customer determines what is going on, what's important to them. We focus on reduction of waste, non-value added process steps, and both rely very heavily on data, because how else are we going to know where we are or where we want to go, or have we sustained our gains? So why do both Lean and Six Sigma? It's a really good way to improve the way we do things and not just cut costs or generate savings. So we're able to identify a savings, but then how do we sustain that savings if we don't change the underlying process? So we can create immediate savings through the elimination of waste, and then we're able to use the Six Sigma methodology to really hardwire those savings over time. Sorry, that's a little sticky today. So why now in healthcare? So obviously we all know about the changing environment that we live in every day, that it's all about value that has to be proved through our changes in our reimbursement structures. So we just wanted to make sure we were staying one step ahead of that curve. Our number one goal is always to improve quality, but number two really needed to be able to find savings so that we could sustain and thrive in this era of changing reimbursement structures. So we look at it as preventative financial maintenance for the organization. We're able to hardwire our financial savings to improve our operating margins so that we really can, going forward, be financially stable. In medicine today, we're always talking about preventative medicine and prevention. Well, this is our financial prevention. So the big question and statement that always comes up in healthcare is, we're not making widgets, we're saving lives. Well, what more important reason to want to reduce variation and have more standardized processes, which is what we do with Six Sigma. So how did we obtain our buy-in? We focused on making data-driven decisions. We know that 99% is not good enough for our patients, that one patient is your mother, your sister, your friend, and we want to eliminate that. So we kind of think of it as perfection on steroids. If we think about 99%, which is the equivalent of 3 Sigma, that's 5,000 incorrect surgeries per week. Now, if we think about 6 Sigma quality, that's 99.9996, or 1.7 incorrect surgeries per week. And then when we go to the prescriptions, it's the difference between 200,000 wrong prescriptions per year to 68 wrong prescriptions per year. Now, these are annual numbers, of course, but it really gives you the scope of how important getting to that 6 Sigma level of quality is. So how do we do it? It's all about choosing the right people to start out with and the right projects. So as far as what staff do you want to be your initial green belts and your black belts? Well, you want some senior leaders, you want physician leaders, nursing leaders. You want those people who are innovative, who are going to help you as an organization think outside the box. And quite honestly, most importantly, you want those unofficial leaders, those staff who are hidden in your departments that know everything that's going on and everybody listens to them, but they're not a manager, they're just, another staff in the department. Those are the staff that are going to help reinforce how well this works, help move it forward, and who staff are really going to listen to. So if you have their buy-in, you're going to move much quicker. The initial projects, they need to be highly visible, have a lot of value to the employee. There has to be a little bit of that what's in it for me when it comes to this kind of projects, and we need quick wins. We need projects initially that have a little bit of low-hanging fruit, those things where we're going to see really good success so that people are going to know the process works. And I think most importantly, and that piece we sometimes forget about, is the communication about what's happening, the publicizing of it. During our initial 3 waves, we were very important to do very regular, every 30-day toll gates, check-ins, where the whole senior team was there. Anybody participating on a project was welcome. And quite honestly, it was open to almost anybody in the organization who chose to come. And the belts, as part of their training, would have to present. Where are we at with the project? What successes are we having? What barriers are we having? And it really makes the projects visible. It increases the ownership of the staff on the groups. So it's really a wonderful way. We continue to do these check-ins on a monthly basis. So even though we may not have an active project going at this point, we're constantly re-looking at the projects that we started back in 2010 to make sure they're still seeing their sustained gains. So that's the other part towards, we get to the later ends of the project. You don't want to lose all the success you had. You want to make sure that you truly hardwired things and just weren't seeing change because we were focusing on it today. We want to be able to move on to new projects and still have the other ones keep their gains. So those check-ins become critical even after the initial project is completed. So one of the examples of a project we did in our very first round was to improve the pre-surgical assessment process so that we could decrease our post-operative respiratory failure. So when we started in 2010, we had a rate of 17 for every 1,000 patients. When our initial project was done, 3 months later, we were able to decrease that rate to 5 in 1,000 patients, which wasn't always easy to do, but it's had a huge success. So one of the tools we're looking at now is a matrix that we use as far as Six Sigma, where we can identify the very first column here. I'll kind of highlight it down. These were the things that the team thought are probably causing the respiratory failure. And you can see 2 of the rows are still white. In the end, those were the only 2 that were shown to be critical, that really had a statistical significance of increasing our respiratory failure rate. And those were exacerbation of pre-op respiratory cardiac issues and fluid overload. So this allowed us going forward to make a lot of changes. From a fluid overload perspective, we worked with our EMS to make sure that as patients came into the facility, we had a clear identification of the volume they got pre-hospital. We redesigned how our operating room was documenting their fluid that they were giving intraoperatively, so that post-op, we had a very clear understanding of how much fluid they'd had. We actually worked with some of our surgeons to decrease the amount of fluids that were being given for certain patients. So it was really a great way to have a huge impact that really was a multidisciplinary effort. Another one that was important for us, though it didn't have such a direct patient impact as the post-op respiratory failure, but had more of an impact on the people in our support services area, was our operating room case carts. So we initially started our project, our ortho case cart had a 24% defective rate. And what we mean by defective rate was everything was clean, but there were not always all the equipment the surgeon needed. So you'd get into the case and they'd have to call down to Central Sterile to have something else sent up. At the end of the project, we had a 3% defective rate. So how did we do that? Well, what you see here is a beautiful diagram of our Central Sterile room, where all of these orange are where the supplies were, and these spaghetti lines were the number of round trips and how the staff had to walk to take the supplies off the shelf and fill the cart. So prior to anything happening, we had to make 16 round trips for our Central Sterile tech to be able to complete a single total hip case cart. When we were done and had redesigned the layout of the storeroom, they now only had to make 3 round trips. So from a buy-in perspective, from what's important to the staff, this was huge. So it was kind of funny. He presented actually with the team at one of our toll gates and basically said, he thought the Six Sigma was a bunch of front office paperwork. but it really works. It's made my job better than it was before. And that's the fundamental core, is it's the staff helping to make changes and improve processes in work that they do every day. So it helps with staff empowerment, and so from a number of perspectives, it just creates a very nice culture amongst the staff. So as far as our organization karate team goes, there is a little over 70 yellow belts at this point, 25 green belts, 8 black belts, and actually the master black belt is now 1. So the director of our process engineering department is currently our only master black belt. And that's just a picture of some of the staff. So you can see, I have providers, I have OR staff, I have office staff. We have staff from the lab, from pretty much every entity within the organization. So what are some of the things, and how do we use the Lean and Six Sigma here at our health system? Well, one of the key things that we've done is we've actually integrated it into our organization. And so our Chief Quality Officer has come up with this very interesting icon, but really it's the Here for Life. It's reminding staff that these 3 things, crew resource management, Lean and Six Sigma, and evidence-based care, are the fundamental core cultural beliefs of how we care for our patients. Evidence-based care. We want to make sure what we're doing meets the best standards. Lean and Six Sigma. We use that as a process tool. We help improve our processes. We're constantly looking for ways to be more efficient. And then we use crew resource management as a way to hardwire and support those efficiencies and those changes by allowing the staff to make the changes that work for them. This is part of our PI plan. Actually, also part of our PI plan is the DMAIC project methodology. So, we all know the Joint Commission requires us to choose a performance improvement methodology. For 20 years, ours was the Plan, Do, Study, Act cycle, which I'm sure many of you know very well. The DMAIC methodology is very similar. Define is kind of what's our aim, and then the measure is our plan, our analyze is kind of our do, improve, and then control. So the control for us was the big thing we were missing with the Plan, Do, Study, Act. It was the loop closure. It was making sure in 6 months, in a year, in 2 years, that we still had the improvements where we wanted them to be. So back in the beginning of 2014, when we approved our PI plan for 2014 with our board of directors, we incorporated the DMAIC methodology into that plan. So really, from the very top of the organization to the very frontline staff, we have incorporated this as how we work. So from a DMAIC perspective, if we do a full cycle, it's 120 days. We'll frequently do kind of mini cycles. So similar to what we would do with PDSA, where you would do a small pilot, see if you needed to make changes before expanding it. We still do that with the DMAIC methodology. It works very well, very efficiently. Some of the other changes that we made within our organization is we no longer have a quality council. It's now our value council. And we've incorporated not only clinical quality kind of outcome measures, we're now looking at some of our cost, our value-based purchasing, some of those other initiatives, along with our patient engagement, patient satisfaction, those kinds of things. We also now use data to support evidence-based care to make truly objective decisions. We had always prided ourselves on being a data-driven organization, and then we had to start doing data for Lean and Six Sigma. And we were amazed that we didn't have as much data as we thought we did, especially when it came to some of the financial pieces to support the measures we were doing. Well, what's the financial impact if we are able to decrease the patient's post-op complications? Like, how much does that complication cost us? So it was really an amazing journey we were able to take. So the toolbox. We all talk about our toolboxes. It ranges from everything from, just that little 2-pack of screwdrivers and a hammer that some of us have in our offices to a full, Home Depot garage with shelves everywhere. So the list of tools you see range from, just a really simple statistical control graph, to the spaghetti diagram that I showed you a little bit earlier with our case carts, FMEAs and cause and effect matrices, cause and effects diagrams or fishbone diagrams, things that as quality professionals we use regularly now have a different way to look at things. So it's really very helpful. Will you ever use all of these on the same project? Not likely. But they're all tools to fit a different project. Flowcharts, deployment, functional deployment flowcharts. These can be really beneficial when you're looking at your staffing to be able to say, do I have the right people in the right place? So we focused a lot, especially early on too, about, as part of gaining staff buy-in of, we're not doing this to decrease jobs. We're doing this to make sure we have the right people doing the right jobs. We were able to say after everything was kind of said and done that yes, we did lose a few positions, but they were all by attrition. So as somebody retired or moved into a new position, we didn't refill certain positions. We were able to redistribute positions so that we had the right people doing the right jobs. It's always frustrating for a nurse on the floor to be having to call the lab or call the storeroom for things. So, that's what the unit coordinator was for. So we were really able to help let nurses be nurses, let, everybody do the job to work to the fullest level of their training. So how did the Lean and Six Sigma impact our patients? Well, we did talk about our post-op respiratory failure improvements. We were also able to decrease nosocomial pressure ulcers by 38%. So what you see here is a little fishbone diagram that we did. So for this project, we had staff from pretty much every area within the organization, from our peri-op area to our ED to our med-surg floors to our critical care unit. And when you said, okay, why are patients getting pressure ulcers? And they came up with 47 reasons. When we re-looked at that, sort of said, well, we can't really attack 47 reasons. Let's get the numbers down a little bit. So we did some multi-voting, and we got it down to really 19 things that they really thought were absolutely imperative to look at. So we did. And over the course of the project, you can see we slowly were able to decrease our mean. Did we ever really truly get to zero, which obviously would be our goal? No. We were able to decrease the overall rates. We were also able to decrease how many days they had the pressure ulcer. So for example, initially patients were starting to develop pressure ulcers on day 2, day 3. By the time we were done, it was patients who, the pressure ulcers were being identified like as the providers were doing discharge summaries. Like we were so close to getting it, but every little step in the way helped. And it was the staff coming up with the things that made the difference. We were able to work with the storeroom, and the creams and some of the things that helped protect the skin weren't stored on the floors. They were stored in the main storeroom. So when the aide had the time to go in and do the patient's bath, the cream wasn't there. So by the time they had to call down and get the cream to come back up, they were on to their next task. So by moving it back up into the floor stock, we were able to get rid of a bunch of rework loops and make sure the patients actually got the care that they needed at the time when they needed it. So what else were we able to do? We were able to decrease the door to EKG time for our patients who are coming in with chest pain from 15 minutes to 5 minutes. So how did we do this? Well, what you're seeing here is a flow diagram. And all of these yellow boxes were non-value added steps, things that we were doing as part of the process as staff that really weren't important to the patient. The red boxes, X's, are steps we removed. And honestly, the most important thing we did, and you see this kind of arrow down here because in our actual flow chart, there's a couple more pages down here. We were able to move the process for the EKG from the bottom of page 2 and move it up to the top. So what we did is we assigned one of our aides in the emergency department with a phone. All of our staff carry phones, but now our nurses do. So now the aide carried a phone that was designated as the EKG phone. So anytime a patient came in, either by ambulance, into triage, with a complaint of chest pain, that aide who had that pager or the phone was called, and they dropped whatever they were doing, and they went into the EKG. We have a procedure room in the waiting, in the triage area, in the waiting room, where they can go in and do one right there. They go right to the patient's bedside, right on the ambulance stretcher, and do the EKG. So taking that step from the bottom of page 2 to basically step 2 was a huge push for decreasing that time to EKG. The other thing we did was create a coaching sheet where we basically had a timeline. Did we call pharmacy to get the TNK and heparin? Did we have the ambulance on standby? Have we called Baystate, who's our transferring hospital, as we don't do primary PCI or have an interventional cath lab here? So we got everything in play. We set up protocols where the patient doesn't actually even leave the ambulance stretcher. Everything is done from the ambulance stretcher to help decrease our times to transfer. So that was a huge improvement, and it was staff determined. This project also incorporated paramedics from our local ambulance services as key players to this project of making sure we have early identification, as well as a patient who had come in with an AMI, had treatment, had gone to Baystate, had an intervention, and was doing very well. So he actually asked to participate in the project. So we've really tried to incorporate as many people into these projects as possible. So you can see for STEMI patients, our arrival to EKG, our goal was 10 minutes. We were able to do that initially in 2012, bring it down even further in 2013, and I can tell you my median time for the end of 2014 was 4 minutes. So we continue to do very well. Not quite at the 3 minutes we want, but we're almost there. So obviously, why is that important? We need the EKG to verify the STEMI to get our door in to door out time decreased as well. So one of the other projects we did was increasing hand hygiene rates to 98%, and in the process, decreasing our nosocomial MRSA and VRE rates to 0.6 per 1,000 patients. How did we do that? Well, interestingly, one of the things we did was what we call a measurement system analysis. We needed to make sure that everybody who was auditing hand washing was auditing it in the same way. So we basically tested the auditors to make sure that everybody was doing it the same way. We also created a standardized approach to auditing. It's very easy when you're going out to look for something like hand washing that you're going to find when it's not happening. And it's just kind of more the rule of thumb. So what we asked was that when you were going to audit hand washing, that you did it for at least 20 minutes in an area so that you could really focus on every opportunity that was available and not just catching the person walking out of the room, and to really focus on that. We also focused on active audits. And what we mean by active audits is if you saw somebody come out and you didn't think they washed their hands, did you go to them, you went to them and said, I just saw you give that patient medication and come out of the room. I didn't see you wash or gel your hands. Did you? And honestly, sometimes they would say, oh no, and they'd try to make excuses, so we would use that as a learning opportunity. And other times they'd say, oh no, look, I used the hand gel right here by the door, and we would say thank you, that's great, and reinforce their positive behavior. Visual reminders. I think every healthcare organization I've been in across the country, you go into the hospital and above hand gel signs or by sinks, there's little signs that say don't forget to wash, how to wash. You need to change those visual reminders. You need to change the color of the paper. You need to change the size of the paper because we get blind to it. You walk by, you just see it, and this way we can have that new cue for staff. They think something different's there, and then they reread it. We really also encouraged patient and family involvement from the perspective that we actually put stickers on all the welcome packets that said, please remind your providers to wash their hands if they haven't. And we hardwired accountability. When staff were seen not washing their hands, the directors or the managers, we built it into our HR systems and with our providers especially. So you can see we, when we initially started, our compliance was kind of variable. We were anywhere from 48 to 76%. For July of 2013, when we were just initiating some of the changes, we were able to hit 94%. And in October, we had actually reached 98%. So we've really worked very hard with this. And again, from a correlation perspective, we have our MRSA and our VRE rates by month, and you can see a dramatic decrease in the right direction. So we had really great improvement for not having to, just making sure we had our staffs wash our hands, which we all know is the best prevention. So hardwiring savings. This was really important for us. So no one said it would be easy. We had to get very creative in how we did this. And this is where we incorporated a lot of the lean principles in with our Six Sigma projects. So when we did our Lean Waste Walk, which we did kind of as our third activity in our journey, we really focused on the 8 categories of waste. We used the acronym of downtime, which even now our staff talk about, and I can walk into almost any department in the hospital and see a downtime sign that basically pretty much looks like this slide where, we talk about, defects. What things are we redoing that we don't need to be? What mistakes are we making? Overproduction, generating more than what's needed. Do we have too many supplies so that we can't find what we really need? Waiting, idle time, non-utilized talent or people. So this is what we talked about, getting people into the right position, allowing them to function at the top of their training. Transportation. Were we moving things too much? Materials, people. We talked about with the pressure ulcer project, just moving the needed supplies back up to the floor from the central storeroom decreased this transportation need. Inventory. Do we have too much, not enough? Is it outdated? That's all, that can all be very wasteful. Motion. That's looking at how does information flow, materials, people, equipment, everything you need. This kind of looks at the case cart case, example that I used earlier, where just by reorganizing the flow of the room, we were able to decrease unnecessary motion. And then extra processing. Are we doing things that don't add value and aren't necessary to get the ultimate outcome? We also looked at 5S. The principle of straightening, shining, standardizing, sorting to be able to maintain established processes. So I don't know about everybody. I can always use to do a little 5S in my house. But so we went into the home of our OR, and we really started driving some of these changes from the front line. So you can see on this side, which was our initial, we can't even close this cupboard over here. Things are falling off shelves. The staff would go to find something and couldn't because there were too many supplies where what they thought they wanted was supposed to be. So we did a 4-hour project where we actually closed the operating room for 4 hours, had staff go in, clean it out, determine what they really needed. As you can see, that same cupboard that I couldn't close in the morning, by the afternoon had empty spaces. Now, one of the things we did with these empty spaces to make sure they stayed empty was we basically put little cardboard boxes, like the preformed boxes, in there so that they wouldn't be tempted, should I say, to refill those spaces. So this allows the ability to keep the space they found free, and now they can just go in, grab what they need, and leave. So that 4-hour effort saved them $22,000 in unnecessary supplies over, if we annualized it. Not to mention the staff being engaged in the process, and because they made the changes, they have been encouraged to keep those changes and to not let it fall back. So I've actually been in there rounding, and somebody will go to put something there, and somebody else will be like, nope, that doesn't go there, put it where it belongs. So they've really taken that empowerment, which is fabulous. So since 2011, our hospital has realized a Lean Six Sigma hard savings of $11.6 million annually. And when we say hard savings, that's because that's what it is. Anytime a savings was identified, either from a Six Sigma project, from a Lean Waste Walk, a Lean Pod, our CFO required it to be taken immediately out of the budget or annualized for the part of the year, and then out of the budget going forward, right down to the object level in the budget. Because if you say you really are counting this as a savings and you've changed a process not to need it, I'm taking it out of your budget so you don't get tempted to use it. And then any variance in budget had to be explained. So from our Lean Waste Walk that we did, we were able to save $5.5 million. And with the Waste Walk, it was kind of cool. We gave different directors a pass where they would go into somebody else's department and walk around. We all know we get blind to what we walk by every day. So having a new set of eyes to say, why did you do that? Or what was the purpose of that? Really made a difference. Usually the walks took about 2 hours, where they would spend 2 hours in the area kind of looking around, talking. Some areas took a little longer, some took a little less, but we averaged about 2 hours. Then we did our Lean Pods, where our senior leaders were kind of given the challenge of finding savings in somebody else's division. That actually found $6.1 million. And then we had some various Six Sigma projects that had some additional ideas. In addition to all of that, staff came up with some great ideas. So by redesigning some of the flow within our Visiting Nurse Association, we were able to increase our capacity without increasing staff, so that we were able to get $750,000 additional income per year. Then there was the service contracts. We changed some. We put a dumpster in to collect metal for scrapping, which gave us some additional income. We did some more contracts for preferred office supplies. We started looking at faxing and scanning instead of FedExing. My favorite example is the isolation patient gloves. So at our hospital, if a patient was on isolation precautions, we had the card outside the door that that had all of our isolation gowns and hand gels and described what kind of precautions they were on. And then once they left the room, we basically did a terminal clean where anything not kind of permanent to the room was thrown away. Well, what that included were the boxes of gloves in the wall. So one of the nurses actually said, if we have an isolation patient, we should just leave the gloves on the cart outside the room instead of in the container in the wall. Because then I'm throwing away brand new boxes of gloves because they were in the room. If I leave them outside, I don't have to throw them away. So that just goes to show the innovation of the frontline staff. And that was actually a $35,000 a year savings. The other big savings from our IV therapy team were IV filter reductions due to our really fabulously low phlebitis and infiltration rates. So we were able to save another $42,000 there. So it was really, a collaborative effort by our staff that was able to help make so many really substantial changes. So what's important to do for hardwiring the savings? Finance has to be part of your team. We had a member of finance work on every Six Sigma project. Every lean pod had a finance person assigned, and everything reported up to the CFO. We had a system to calculate and track our savings. And like I had said, very important to tie the savings back to the individual budget line and then take it away because we all know if the money's in the savings account, we're likely to spend it. And then importance, you have to have, just like we have to track our savings, we also then have to monitor the budget variance and be able to explain what's happening. Otherwise, we'll get that slow drift back of, but we need to increase the budget because, you need to have really solid data to support that. So this process really took a lot of persistence and creativity by everybody. As you can see, the lion is definitely ready to be creative in this case. And you'll be amazed at how quickly your staff just engage it when they realize that it really does improve the care they're giving. Engagement of the front lines. So the projects help. Advertising helps. So these are just some snippets of what we look at. Our annual report, it's been shown. Our scope is our employee newsletter. Our senior team here actually does regular, this is a case where they were dishing ice cream for the people with the graphs of all of our savings behind them. It's just really important for the staff to see that what they're doing is being seen by everybody in the organization. This is our employee portal where we actually have a section where there's references. There's a way to, it allows, there's links here for staff to enter their lean savings so that we can track it. There's ways for individual staff to identify a potential change, a potential savings. Anything they see is responded to by the director of our process engineering department within the next business day, so that they get that immediate feedback. And those are some of the things we've seen, the metal dumpster, the infection control gloves. Those things came from staff through this kind of system. So this is kind of an ongoing way. And we tell all staff about this during orientation, so it continually gets incorporated within the organization. So we have to make it easy for them to be involved. So as a recap, we've talked today about why it's important to do both Lean and Six Sigma, how to get some buy-in from our staff and providers, project selection, the importance of picking those initial projects so that we can really see, staff can see the value in it, how integrating it into the organization from the top down becomes critical, the variety of tools that we have available, how we can have some really substantial impact on patient outcomes as well as our financial outcomes, and why staff engagement is important. So I will ask Jean to unmute you guys, so if anybody has any questions.
The conference has been unmuted.
Thank you, Casey, for taking the time to share with us today all of your expertise in Lean and Six Sigma. Fantastic. Just want to remind everyone before we get into questions and answers to please complete the survey at the close of this event in order to earn your CEU. And we'll turn it over to questions and answers.
Casey, this is Lynn Myers from Tufts Medical Center. An excellent presentation. Thank you so much. I noticed when you showed the screenshot of your website there that you had a little thing on the side called Waste Walk Observation Form. Can you talk about that just a minute?
Sure. So we wanted to, when we did our waste walks, and we still encourage our directors to do them because we do a lot of rounding. It was a standardized form, and it actually, when they fill it out, it goes into a database. So it basically identified what they thought the waste was. So was it the fact that they were printing to a color printer versus a black and white printer? We'd even gotten to the point where we don't buy colored folders anymore. We only buy the manila because they're cheaper. So it was really just what did you see as what you considered waste, and what you suggested as the improvement, and then it tracked like the area, the date, who did the observation, who it was reported to.
Open up the survey and fill it out.
So we didn't have a set of standardized observation questions. It was just a standardized form to record their observations.
Correct.
Excellent. Thank you so much.
Sure.
I'd like to remind everybody, hi, this is Jean Dufresne. I'd like to remind everybody that all lines have been unmuted, so if you could please be respectful as questions and answers are going on, because we can hear people talking in the background. Thank you.
Hi, good afternoon. Casey, excellent presentation. My name is Juanita Prescott. Your EKG chest pain study, when the aide that had the phone dropped everything, did you have something in place that would not affect patient care on the other end downstream?
Yeah, so the aide that had the pager for the day was always kind of working with another aide. Like we never gave her an area where she'd be by herself. So like we have an express care, we have a main department, and then we have kind of a cardiac trauma area. We would always have her in the main, her or him, in the main area where there are generally two aides, and people kind of knew that that was their secondary role for the day. So the tasks they were given were almost never those critical tasks that we would normally give, knowing that they might have to change it.
Oh, okay. Thank you.
Casey, I have a question. When
Sure.
you're looking at your Six Sigma toolbox, and we saw all those wonderful tools within there, how do you know which one to use? Are they specific to projects, or is one better for a specific project than say another, or how do you decide that?
Sure. For some of us, so my background, in addition to being a black belt, I come from our performance improvement department. So there's a performance improvement specialist like myself assigned to every area. 3 of us are black belts, 2 more are green belts, everybody else is a yellow belt, but also has additional training in these tools. So we really work with the area, look at the project. There's some tools like a flowchart, a Pareto, an SBC graph that every project is going to use because those are going to show you your basic what's going on. But like an MSA, for example, like in the hand washing project, you're not always going to measure your analysis tool. But sometimes if you're not sure what's going on, it can be really beneficial. So that's where we kind of go back to, and we rely on the black belts and the master black belt within the organization to help make some of those choices.
Okay, great. Thank you.
Mm-hmm.
Casey?
Yeah.
This is Lynn Keeley from Whittier Rehab.
Hi.
I'm just curious as to way back when you guys first started, was it your performance improvement specialist that got trained and then came in and trained everyone else?
Interestingly, no. So our COO brought in an outside company, a consultant, who worked with our COO and our CFO to kind of lay out what they thought the organization needed.
Okay.
And in the first wave, she trained 8 of our staff as green belts. In the second wave, she trained another 8 in green belt. Then in the third wave, they picked some of the green belts from the first 2 waves and trained them as black belts.
Okay.
So it was kind of a staged approach. And then one of the staff who was in the original group who did well as a green belt was actually sort of picked to be the one who would sustain the program here. So she then worked with the consultant, got trained as a black belt, learned how to teach the classes, what was expected, and went on to get her master black belt. And she's the one who kind of helps keep everything coordinated. Since a lot of us as green belt, or the rest of the belts, all have other jobs, so to speak, and we do these projects on an as-needed basis.
Okay. Do you remember the name of the company?
I do. We used Lynn Sisak. She had actually been recommended, I believe, by maybe South Shore.
Okay. And she came right to your organization.
Yeah, she came. Yeah, it was kind of a contractual thing where she did the classes on site. She spent so much time each month here.
Okay.
And it's just really important, no matter who you pick as that kind of consultant person, that they work with you to give your organization what fits within your structure and your culture. Because there's a lot of different ways to do it. Some people go full board with Lean first. Some just do Six Sigma. We chose to kind of do some Six Sigma, then kind of give everybody a break because it's very labor intensive for the staff who are part of the project.
Yep.
And that's when we did some of the Lean stuff. And then we went back at it with some more projects. So I think from a staff perspective, that was really important. Like especially in your areas with a lot of opportunity, like your ED, your OR, who are going to get hit with a lot of projects. we always made sure that no one area got hit with 2 projects in the same cycle.
Okay.
So that's another important piece.
Great. Thank you so much.
Sure.
Hi, this is Jean again. To be respectful of everyone's time, it is the top of the hour. We have time, Casey, if you don't mind, for one more question, if
Sure.
anyone has one.
Oh, hi, Casey. This is Patty Gordon at Leahy Clinic.
Hi.
Thank you again for the presentation. It's been really informing. One quick question I do have. I actually have 2.
Sure.
The first one is on the sustaining. And do you have a sense of how well you're sustaining those measures, like in 2014, compared to how you were sustaining them back kind of when the projects were new?
Sure. Well, I mean, I can tell you for EKG, for example, we were in the end of 2013, we were at 5 minutes. At the end of 2014, we were at 4 minutes.
So that's great. So even though you had changes in staff, you're able to keep the sustained improvement. That's great. Can I also ask one other question, too, about the hard savings?
Sure.
Was that a difficult message across the organization, or to say that you're going to do an improvement, that the savings that you bring as a result then get cut out of the budget? Am I understanding that right?
Yeah, no, I mean, not really, because we focused on the fact that it was waste. It was things that weren't being beneficial to what you were doing. It was like extra supplies. It was contracts. It was those kinds of things.
Okay.
It wasn't impacting the things they needed to do their job, which was really important. And I think the only person.
Never know.
Yeah, exactly. So I think that was really the key. Yeah, so that worked out really well, actually.
Great. Thank you.
You're welcome. And just as everybody's starting to go, the last slide does have my email. If you have any other questions, please feel free to email me. I will get back to you.
Okay, ladies and gentlemen, that's going to conclude our presentation for today. If you could please take a minute to complete the survey to earn your CEU. And thank you very much. Thank you, Casey.
Thanks.